I think everybody has to get up. I think people will come as they will come. So we're going to get started. I think we've got people online as well as at different physical locations. We actually have we convinced one cardiologist to stay because cardiology rounds got canceled. So he too will learn about anemia and take that back to the cardiologist. So it gives me great pleasure to actually introduce Dr. David Wheeler, who's a professor of medicine at University College London in the UK. And he's come from the UK last night, so I think he's well into his day today from a time zone perspective. He's been an important participant and driver of a lot of clinical trials in nephrology, including lipid-lowering studies, calcimimetics, sodium glucose transport inhibitors. He was one of the driving forces behind the Vanguard study before SHARP, and then a driver in the UK of the SHARP study. He actually has a number of very important roles in international nephrology, including being an honorary professor fellow of the George Institute in Sydney, a prior KDIGO, Kidney Disease Improving Global Outcomes chair for Just Step Down in 2019, and has been really a driving force as well in a new entity in the UK for a clinical trials network. And so I've known David for quite a while. We started in the anemia business quite a while ago, and he's an outstanding scholar and gentleman, and I'm really pleased that he's here to tell us about what's new in anemia. And so, as you know, we are having a roundtable discussion after this for those of you that want up in the GI conference room, but we'll get to that afterwards. So welcome, David.
Yeah, I thought you said he was going to tell us the results of the election.
That too. Well, thank you very much, Adira, for the invitation to come and speak with you here in Vancouver on a Thursday morning. We won't know our election results until 10 o'clock UK time tonight, so I'm afraid I can't give you those just yet. But we're all watching and waiting anxiously. I'm going to tell you about where I think we currently are with anemia management in chronic kidney disease. And I'm an evidence-based sort of person, and my talk is based largely on clinical data from clinical trials. So here are just my disclosures before we start. And here is my first slide. Now, this is from the NHANES data set from the US, and just makes the point that in patients with lower levels of kidney function, and this is creatinine clearance in this slide, there is a lower level of hemoglobin. So you can see here that even in patients with creatinine clearances between 40, 50, 60, there is the suggestions here of the development of anemia. So patients with chronic kidney disease have anemia, and it develops early. And I couldn't resist starting with one of your local studies here from British Columbia. This is a study from a little way back now in 2006, looking at the relationship between hemoglobin levels and outcomes in non-dialysis CKD patients. Now, this is observational data, but you can see from these observational data that patients with the higher hemoglobin level, here in green, did best, and patients with the lowest hemoglobin level, here in red, did worst. And of course, this kind of data allows you to generate the hypothesis that improving hemoglobin levels with some sort of intervention may improve outcomes for these patients. This is survival. Could we improve the survival of these patients by moving them into this group? And that's a hypothesis, and you can't prove that hypothesis for an observational data set like this. You need to do a clinical trial. Renal anemia is complex. I'm not going to go into a lot of detail here. I just want to highlight the fact that the main drivers are a lack of erythropoietin production from the kidney, leading to lack of stimulation of the bone marrow to produce hemoglobin. So this is an issue here. I think I need to go on this side. Here we go. Lack of erythropoietin production from the kidney, leading to lack of stimulation of the bone marrow to produce red cells. And I want to point out as well the role of hepcidin here. So hepcidin is an inflammatory protein released in the context of inflammation that impairs iron metabolism. And one approach to management of renal anemia, particularly from the iron side, is to actually deal with this high hepcidin level, and we'll come back to that a bit later on. So two major drivers we're going to focus on here. One is the decrease in erythropoiesis due to reduced erythropoietin production from the kidney, and secondly, the high levels of hepcidin inhibiting various aspects of iron metabolism. So I'm going to talk about our therapies for anemia. I'm going to start briefly with transfusions, and I'm going to end with HIF stabilizers or prolyl hydroxylase inhibitors. I'm old enough to remember going onto a dialysis unit and seeing red bags of blood hanging up at most of the dialysis stations as we were transfusing patients to top up their hemoglobins. We used to transfuse them when their hemoglobins got down to about 6 and they felt symptomatic. They had a transient benefit from this. We possibly spread infection. We sensitized them and made transplantation more difficult. And we might have iron overloaded a few of our patients, but this was the optimal therapy in the 1980s when I was a junior doctor. And then erythropoietins came along, and I'm indebted to Ian McDougall, my colleague and friend, for providing this slide, which was one of his early studies of 10 hemodialysis patients giving erythropoiesis stimulating agents. We started at 6.5, took their hemoglobins way up to 12. That's a 5 grams per deciliter increase in the space of just 4 months. But these patients felt much better. They thanked us for the therapy, and I think many nephrologists felt that erythropoietin really was a new wonder drug for this particular patient population. And the early studies, to some degree, endorsed that. So we're going back to the 1990s again here, back to the 1990s. We see here a randomized controlled trial achieving 2 different hemoglobin concentrations with 2 different doses of erythropoietin in 118 hemodialysis patients with a starting hemoglobin of less than 9. And there was a placebo control in this trial, allowing the investigators to compare the effects of the 2 doses of EPO with placebo. And sure enough, there were benefits in terms of improved global and physical function, distance walked during an exercise test, but some worrying signals, even in this small study, with an increase in diastolic blood pressure and vascular access thrombosis, and you can see the numbers here. So even way back in the 1990s, we were beginning to see some worrying signals as well as some of the benefits of the EPO therapy. So along came 4 outcome studies. Normal hematocrit study, 1998, Choir and Create in 2006, and the TREAT study in 2009. And these studies completely changed the way we used erythropoietins. And I'm going to talk you through these and how they changed our practice. So way back in 1998, it was considered unethical to randomize patients on hemodialysis with anemia to a placebo. And so this trial compared 2 different doses of ESAs to achieve 2 different hemoglobin concentrations. No one would entertain the idea of a placebo. And you can see that they're old blue slides, but this is the difference in hemoglobin achieved in the 2 groups. So this is the lower hematocrit group, hematocrit of 30%, higher hematocrit group, 42%. Here's the primary outcome, probability of death or MI. And look, the patients with the normal hematocrit, the patients in whom the investigators normalized anemia, showed a worse outcome than the patients who were allowed to run with the lower hemoglobin or hematocrit levels during the study. And there was an increase in vascular access thrombosis in this higher hemoglobin group, and the trial was stopped early by the Data Safety Monitoring Committee. This was exactly the opposite to what we expected. There were a number of review articles and editorials at the time explaining why this result was wrong, but we persisted and continued to push hemoglobins up to levels that perhaps in retrospect were too high. So we didn't believe that result. Then Choir and Create came along, 2 studies in non-dialysis CKD patients. This is Choir, 1,432 CKD patients not on dialysis. They had anemia, 2 different ESA concentrations to achieve 2 different hemoglobin ranges, composite cardiovascular endpoint, again stopped early by the Data Safety Monitoring Board, again because there was an adverse signal in the patients who were in the higher hemoglobin groups. Here are the numbers of events. Here is the hazard ratio, and you'll see that these patients were experiencing significantly more primary outcomes, mortality, stroke, MI, or hospitalization compared to the patients in the lower hemoglobin group. Pretty much exactly what we'd seen in the low hematocrit, in the normal hematocrit study. And alarm bells started to ring. The CREATE study, published at about the same time, in fact, the same New England Journal of Medicine issue contained both of these studies. 603 CKD patients not on dialysis, 2 different hemoglobins, composite of cardiovascular events, nice separation of hemoglobin levels, absolutely no difference in terms of cardiovascular outcomes in this case. So after these 2 studies, the warning bells began to sound, and this is from the New York Times, black box warnings placed on the use of erythropoietins in patients with chronic kidney disease. Doctors should use these drugs at the lowest doses possible to avoid transfusions. We'd gone from pushing hemoglobins to back into the normal range to backing off and using these drugs really cautiously in patients with chronic kidney disease. And we did that because of evidence from those trials. And then at last, we'd been using the drug for 20 years before we did the placebo-controlled study. And this was the TREAT study, 4,000 patients with type 2 diabetes and chronic kidney disease, darbepoetin or placebo, a co-primary endpoint here, nice separation of hemoglobins, placebo and darbepoetin alpha, but absolutely no benefits in terms of cardiovascular events. So here we have a placebo-controlled trial showing that giving erythropoietins and increasing hemoglobins by doing so has no benefits in terms of cardiovascular outcomes. And again, this was a shock, I think, to many people. And not only that, but there were some worrying safety signals in this study. Here is stroke, vascular access thrombosis, arterial thromboembolism, and cancer-related mortality, so cancer deaths, all higher in the darbepoetin-treated groups compared to placebo. And there was a worrying signal here in patients who'd had a prior cancer getting a recurrent cancer rather more quickly after they'd been given this erythropoietin growth factor therapy in this study. So we took a deep breath and we stood back from that and we rethought the way that we managed anemia. So just to summarize these studies, you can see that between 1998 and 2009, we learned that pushing hemoglobin levels too high was harmful, and we finally learned in 2009 that against placebo, erythropoietins didn't seem to have any outcome benefits. And the guidelines at around about that time backed off these high targets, and this is just a summary of a number of different guidelines from about 10 years ago. We should correct or partially correct hemoglobin to get hemoglobin levels just above 10, perhaps individualize in some patients to achieve higher levels if the patient's really going to benefit from those higher levels. But the target is not normalization of hemoglobin, but partial correction using the lowest dose of ESA possible. And certainly when I'm treating patients now with ESAs, I begin to wonder, or I begin to ask myself and talk to the patient about what we want to achieve. There is an increased risk. Is the patient really going to benefit from that partial correction of anemia? And you've really got to know that your patient is going to gain some benefit from the intervention before you start the drug. So let's move on to iron. If we can't use a lot of ESA, could we use a little bit of ESA and a lot of iron to help our patients? Now, you're going to tell me that this is not iron deficiency anemia. We all know that. But by pushing iron into our patients, we get a better ESA response. You're also going to tell me that these patients don't absorb oral iron, which of course they don't, and that they may develop adverse reactions to intravenous iron. So you want some data, and I'm going to show you some data. We've known for a number of years now that giving iron with ESAs, particularly intravenous iron, in patients on hemodialysis improves their hemoglobin response. So back to one of Ian McDougall's early studies, These are all hemodialysis patients. They're all on ESAs. They get no iron in red, oral iron in orange, or intravenous iron in green. They only benefit in terms of hemoglobin response when given the intravenous iron. They don't gain benefit from oral iron. And similar work from the US, Steve Fishbane, intravenous iron, oral iron, better hemoglobin response to the intravenous iron in this population of hemodialysis patients. But there's a worry here, and again we go back to the observational data. And these are data from DOPS. This is monthly dose of intravenous iron given to these patients. Again, of course, this is observational, as I said. Here's the reference range of 100 to 200 milligram per month of intravenous iron, not an unreasonable dose. Patients receiving higher doses of intravenous iron here have a higher risk of mortality from cardiovascular disease-related events and from infections. Some of these are trends rather than being statistically significant, but you can see here a clear worrying signal suggesting that these patients who are getting more iron here have more deaths due to these different causes. And this made everybody a little bit cautious about giving intravenous iron, along with a story from the laboratories that if you gave iron, you promoted bacterial growth and patients were more likely to get infections. So this was a study we did in the UK. This is a 50-center site that we did of intravenous iron in patients on hemodialysis, sponsored by Kidney Research UK and supported by Vifor Fresenius. Our hypothesis was that if we gave high doses of intravenous iron to patients on hemodialysis, along with their ESAs, that this would be non-inferior or possibly superior to a low-dose iron regime in terms of all-cause mortality and non-fatal cardiovascular events. This study had a probe design, so the investigators and the patients knew what they were getting, but those analyzing the data didn't know the therapy allocation. And this is our trial design. We took incident hemodialysis patients here. They'd started dialysis within the previous month, ferritins of less than 400, TSATs of less than 30%, and we randomized 2,141 of these patients to a proactive high-dose iron regime, where the patients got 400 milligrams of intravenous iron. This is iron sucrose per month, unless their ferritins were above 700 and their TSATs were above 40%, or their TSATs were above 40%, or patients were randomized to the reactive low-dose iron group, in which they only got the iron if their ferritins dropped below 200 or their TSATs below 20. So in these patients, we're pushing IV iron, stopping at a ferritin of 700 or TSAT of greater than 40%. These patients are only being given iron if the ferritin or TSATs drift down below 200 and 20% respectively. And we chose these limits after a consensus at one of our national meetings that sets these two different ferritin concentrations. These were considered by my colleagues to be reasonable levels for ferritin in the two arms of the study. Endpoint-driven study, we needed 631 events. These were all-cause mortality or non-fatal cardiovascular events. The study ran for a median of 2.1 years, maximum of 4.4 years. And we presented this study at the American Society of Nephrology last year, 2018. We managed to achieve a difference in exposure to intravenous iron. Here's the high-dose group in purple. Here's the low-dose group in blue. Cumulative doses here almost double in the higher dose group in the first year of the study. So the higher dose group are definitely exposed to higher levels of iron, and that is reflected in this increase in serum concentration of ferritin that occurs quite early on in the trial, and this is seen also with the TSATs that I'm not showing today. So here we managed to achieve this ferritin of nearly 700 in the proactive group and around about 200 in the reactive iron group. So here's our primary outcome. This is first a test for non-inferiority. So we first asked, was the reactive was the proactive high-dose iron group non-inferior? As you can see here, there were actually numerically fewer endpoint events in the proactive high-dose iron group. P-value of 0.001, 15% reduction in this composite primary outcome, favoring the proactive high-dose iron. We then went on to test for superiority, and we got a significant p-value here. So we can say that this proactive high-dose iron regime was statistically superior to the reactive low-dose iron regime in preventing this composite of clinical events. This was death from any cause. This didn't quite reach statistical significance, 16% fewer deaths, but a p-value of 0.54. So just looking at the cardiovascular events in a little bit more detail, these are the cardiovascular events here that are included in the composite primary endpoint. Here's fatal and non-fatal MI and heart failure. And you can see here significant reductions in these events, particularly non-fatal MI and hospitalization for heart failure. So the main benefits from the higher dose intravenous iron seem to be linked to fewer cardiovascular events in this study. We stratified patients depending on how long they'd been on dialysis, whether they had a catheter in place or they had a fistula, and whether or not they had diabetes at baseline, and we saw no differences here. So these are tests for heterogeneity. These numbers are not statistically significant, meaning that these values are not significantly different. So across the board, we seem to be seeing benefits in our patient population. And what happened to hemoglobins? Well, the investigators were allowed to dose ESAs as they wanted to. We let the investigators manage the erythropoietins during this study. Inevitably, they used more ESAs in the patients on the reactive low-dose iron regime. But you can see that the investigators did a good job of maintaining hemoglobin levels with the ESAs. And after this initial lag phase, the hemoglobins in both studies are similar, although, of course, there's a difference here at the beginning. So the patients had similar hemoglobin levels, but that was achieved with higher doses of ESA in the reactive low-dose iron group. So the reactive group that did worse got more ESA and more ESA and less iron. The proactive group that did better had less ESA and more iron, similar hemoglobin concentrations. So different ways of achieving that target with different clinical outcomes. How about safety? There's the worries that I mentioned at the beginning about safety of intravenous iron. No enhanced risk or significantly enhanced risk of vascular access thrombosis. No difference in all-cause hospitalization. We collected data on all infections, and there were no differences in infection rate between patients receiving the low-dose or the high-dose intravenous iron. You remember that this was the big worry with these therapies, was the increased risk of bacterial infection, seen in the lab, not seen in the patient. So just to summarize, we felt that the proactive high-dose iron regime was superior to the reactive lower-dose iron regime, fewer cardiovascular events, reduced ESA dosing, and no increased risk of infections. So these are the sort of current guidelines on iron use. Use supplemental iron, yes, of course. Intravenous in hemodialysis patients. You can try oral in non-dialysis patients. We'll come back to that in a little while. I'm not sure that these ferritin recommendations are now right with the pivotal study. I think we can certainly go up to 700. I don't think we want to leave patients around the 100. I think it's safe to push them up to nearer 700, so maybe this range will change in future guidelines. And maybe we can go above 700, but of course we didn't do that in pivotal. And I've said here, and I think this is true from the guidelines, I don't think we know the upper level of ferritin that we can push patients to using intravenous iron. So in the last section of this talk, I'm just going to look into the future, because I think the new drugs coming along could change everything and could change the way we manage renal anemia. So just bear with me through a bit of physiology, and the clever doctors who described this pathway have just got the Nobel Prize for Medicine, and one of them, Peter Ratcliffe, is a nephrologist from Oxford in the UK, so we're very proud of that. But what this group described was the HIF, or hypoxia-inducible factor pathway. In normal oxygen saturations, as we are in this room, HIF-alpha, which is a transcription factor, is broken down by an enzyme called HIF-prolyl hydroxylase. Breaks into little pieces, has no effect. It disappears. So the normal situation under normal oxygen tensions is that HIF-alpha disappears. When we are exposed to hypoxia, the prolyl hydroxylase inhibitor enzyme doesn't work. It is inhibited by the hypoxia. The HIF-alpha is not broken down, migrates into the nucleus, dimerizes with HIF-beta, and upregulates the expression of a number of genes important in the erythropoiesis and iron pathways. So, for example, these genes increase EPO, they increase iron absorption, they reduce hepcidin levels, and high hepcidin levels inhibit oral iron absorption, and they enhance the transport of iron to the bone marrow. I'll show you that in the next slide. But all of these coordinated events lead to an increase of red blood cell production, which of course is exactly what we see when we go up to altitude, and this is why athletes train at high levels. So all of these coordinated responses increase red blood cell production. So if you think about this, if we could inhibit this enzyme pharmaceutically, pharmacologically, perhaps I should say, then we can mimic the effects of hypoxia. And that's exactly what HIF stabilizers do. They inhibit prolyl hydroxylase enzyme, and they mimic the effects of hypoxia in normal oxygen tensions. So they stabilize the HIF-alpha, and this process of regulation of erythropoiesis and iron metabolism is facilitated. So here are the HIF-sensitive proteins, effects here on transporters that are responsible for the absorption of iron from the gut and transport of iron into macrophages, reductions in that protein hepcidin, which inhibits oral iron absorption, increases in transferrin and transferrin receptor expression, allowing transport or enhancing transport of iron from the gut to places or sites of erythropoiesis, mainly, of course, the kidney, and increase EPO receptor and increase EPO receptor expression. Now, you can imagine that for these drugs to work, there needs to be a supply of erythropoietin available. And I think what surprised everybody is that these drugs do enhance erythropoietin patients, even in patients who have virtually no kidney function, and even in patients with no kidneys. So there has to be another source of EPO in the body other than the renal interstitial fibroblast. Pros and cons. These drugs provide a physiological EPO profile. What do I mean by that? They nudge erythropoietin up into the range that erythropoiesis occurs without pushing EPOs into the pharmacological range that we usually achieve with the injected ESAs. So they correct EPO levels into the normal physiological range rather than into the high therapeutic ranges that we use when we inject ESAs. They're active orally, so we don't need to inject them. They're probably going to be cheaper to make, well, they are cheaper to make than the ESAs, which require recombinant technology. They have multiple gene targets. That's a pro and a con, because there are worries about off-target effects. And I think in this next slide, I show a range of various transcription factors and mediators that are modulated by HIF. And there are some growth factors here that we might worry about in the context of cancers. And so I think there's a big question mark over the safety of these drugs long term, particularly in terms of cancers. So 3 of these drugs now, roxadustat, daprodustat, and vardadustat, have reached phase 3 studies and will be coming our way soon, if they're not here already. A few highlights from the phase 2 study trials. These are hemodialysis and PD patients. They receive roxadustat, all of them, so all of these patients get roxadustat. There's no placebo. They get it as a twice-weekly oral dose. There's no iron, oral iron, and IV iron. So here in red, there's no iron given, and here in blue and in green, here, you'll see similar hemoglobin responses in patients who received intravenous iron and oral iron. So we don't expect to see that in the hemodialysis population. These patients, given the oral iron, show a similar hemoglobin response to those getting the intravenous iron. Remember that hemodialysis patients don't normally absorb oral iron, as I showed you way back at the beginning. So there's something interesting going on here in terms of iron absorption, and that may be related to hepcidin levels. So here's another study, roxadustat. There's a placebo here in red. There's different doses here in the different colors, but here's hepcidin levels in the bottom left here, and you'll see a dose-dependent suppression of hepcidin, the protein that inhibits oral iron absorption. Now, what's getting more exciting now is that we're beginning to see the phase 3 studies coming through. So the first phase 3 study was published by a Chinese group earlier this year in the New England Journal. Roxadustat versus epoetin alpha, 2-to-1 randomization, IV iron as rescue, and the primary endpoint is the difference between the baseline and the follow-up hemoglobin concentration over this range here from 23 to 27 weeks. So you can see that both roxadustat and epoetin alpha allowed correction of the anemia with stability here, and in the statistical tests here, the roxadustat was non-inferior to epoetin alpha, so as good as epoetin alpha in correcting the anemia, and that was the primary outcome of this study. But there were some other effects that were interesting. In the roxadustat patients, there were higher ferritins, there were better maintained levels of serum iron and TSATs, and there were lower blood cholesterol levels. And what I should say from the downside was that there were slightly higher potassium levels as well, and more episodes of hyperkalemia. And here's the hepcidin again, drop on the patients, or drop in the patients receiving the roxadustat in blue, no real drop in the patients receiving epoetin alpha. So it looks like these drugs work via a different mechanism. What I found particularly interesting was here we're looking at inflamed patients. So the patients in the darker color here, in the darker blue here on the left for roxadustat, and in the red here for patients on epoetin alpha. These inflamed patients showed a better response, in fact, on roxa compared to the patients who had normal levels of CRP. I shouldn't say better, they're very similar, I guess, here, but these patients with infections, if you like, and higher CRPs are responding to roxa, whereas on the right here, looking at ESAs, we see this expected failure to respond to the ESA in those patients who had the CRP above normal. Now, it's small numbers, I agree, but it potentially suggests a different mechanism of action. So we do see the expected increases in hemoglobin with these drugs. We can maintain hemoglobin when we switch from ESAs to these drugs. Different mode of action. Some other off-target effects that are quite interesting. And to date, no major safety issues, but we do need to look long-term to understand what the potential safety concerns are. And there are some big studies going on. These are two studies of daprodustat, 4,500 patients on dialysis. This study is fully recruited. This study is fully recruited. The D study, 3,000 patients on dialysis, 4,500 patients here not on dialysis, looking at MACE as an outcome. So big studies, long follow-ups, and we're going to see more data on these drugs coming through. So I hope that we'll learn from these studies whether these drugs are safer than ESAs from a cardiovascular perspective, they may or may not be, and whether there are any long-term concerns, particularly regarding malignancies, remembering those signals we saw in TREAT with darbepoetin alpha. So if you're drifting off, this is the time to wake up. The ESAs initially showed promise, but I think we used them probably incorrectly and too enthusiastically, and I think looking back we could have done a better job with those early studies, done the outcome studies earlier on, used the drugs properly and got more from them. The intravenous iron, I think, allows us to get away with a lower dose of ESA, so we can give bigger doses of iron, lower doses of ESA, and get a hemoglobin response. And as I hope I've demonstrated in the last few slides, I think the HIF stabilizers could change things dramatically, remembering that we've still got that question about long-term safety. Thank you very much for listening.
The white part. Oh, there we go. Okay. Sorry. It's been a while to figure out the button. I have a question for you about the studies that are coming up for the phase 3 studies for the HIF stabilizers. Are they designed as superiority trials for composite for cardiovascular outcomes? Obviously, compared to a drug that we know is worse than placebo. Are they alternatively designed as a non-inferiority trial? And if they are, what's the inferiority margin that we would accept against a drug that we already know is worse than the placebo drug?
Great question. So these are FDA-required cardiovascular outcome trials looking at cardiovascular safety. It's a bit like the diabetes drugs, and the FDA have requested these trials. The general theme of these trials is you either take a patient who's already on an ESA and you switch to a HIF, or you randomly switch to a HIF or continue the ESA, or you take a patient who's not on treatment and you randomize to placebo or to the HIF. So these trials include patients who were already on ESAs, randomized to stay on ESA or to start HIF, and patients who weren't on anything randomized to continue placebo or go on to the HIF. So we'll see both of those comparisons in these trials, and we'll be able to do subgroup analyses on those comparisons. So the trials are really looking at the safety of the regime, of a HIF-based treatment regime as opposed to an ESA-based with iron-based treatment regime. And I hope we'll be able to tease those questions out from the trial.
I guess what I'm wondering is, what will we accept in order to start, or to have drug approval and then subsequently use these drugs? If they're looking at a MACE as an outcome, do we demand that they're actually better than EPO in terms of a superiority trial, considering we know EPO is already bad for you? Or are we accepting the fact that they may be not worse than EPO, but then that's comparing to a treatment that we know is bad?
So I think what the regulators want to know is that they're no worse than ESAs. What we do with that information, I think, is the interesting question. So if we've got an oral alternative that's potentially cheaper, that takes away the worries of iron, that still works in patients with an elevated CRP, will that be a more attractive therapy than our current injectable ESA with regular iron dosing? And that's something I think you have to decide in your own practice. But that is the potential that we're unlocking here. And I think how we do this, is interesting.
I guess I'm just wondering about the potential for creep over time. I mean, what's our non-inferiority margin here? Is it less than 10%, worse than EPO is okay, but over time you can have a drug that gets even worse and worse and worse compared to placebo, as opposed to the pivotal trial where you demonstrated, a small absolute reduction in risk, but at least an absolute reduction when we try to minimize EPO through iron use.
Yeah, no, great questions. And there was a margin in that New England Journal study, and I can't remember off the top of my head what it was. But, we're looking here short term, and we will have to do, I think everyone's agreed, post-marketing surveillance studies of these drugs. If they're as safe in these shortish term studies, and these are shortish term studies, this is 52 weeks. If they are safe over 52 weeks, we may want to use them, and then we're going to need to follow those patients up long term, I think, in registries to convince ourselves that there isn't a long-term harm issue, rather than making the mistake we made with the ESAs, which is just to assume they're okay without outcome trials, and do the placebo-controlled trial late in the life of the drug.
I think, I mean, just to add to, I think what Sean's also, the difference between what you need to do for the regulators to get it approved to the market is very different than the questions that clinicians need to answer. And I think, as we've discussed in these fora before, the problem with nephrology is we haven't answered the question, what's the right hemoglobin, what's the right outcome that you're looking for with treatment of hemoglobin, and these studies don't answer that. They just say, does a HIF make your hemoglobin higher with a relatively good safety signal, period. And that's the problem, is that we're still going to be left with what is the right hemoglobin. And even though the guidelines say individualized targets, that's my segue, we don't really actually practice that way. Not for dialysis versus non-dialysis, with vascular access, without vascular access, et cetera. So maybe, your thoughts on, do you think that we'll ever get to doing, and because we have a cardiologist, like more cardiology trials where it's about the outcome that matters, not making the number different?
I think we really need to go back and ask why we're prescribing ESAs to our patients, to be honest. And I think it's to stop them needing transfusions, and it is hopefully to make them feel better on an everyday basis. And that's hugely important to patients on dialysis, is how they feel, whether they can think, how their brain functions, and whether they can cope with the day. And I think, that patients' expectations differ in that respect. And I think, the right way is to individualize therapy to each patient and to revisit the patient to see whether they have benefited from whatever hemoglobin you've achieved and whether you might want to go to a higher dose, accepting the risks. And those risks could be, in a patient who's had a prior stroke or prior cancer, a recurrence of that pathological problem. So I think it's, the ESAs are not easy to use, they're not easy to monitor, and I think we've got to think very carefully about what we're trying to achieve in each individual patient. And we can't do that in our service in the UK, where we're looking after 1,000 dialysis patients from our centre. We have not got time to individually ask patients whether they like their ESA and they want their hemoglobin a bit higher. It's all protocolized, and ESAs don't work well in a protocolized, healthcare system. But we need to do more. We need to do cardiovascular outcome studies, and we are doing them.
Question from Victoria. It's Kevin Horgan here. Really enjoyed the talk. Just following up on the conversation there about target hemoglobin, while we're waiting for the HIF story to unfold, does it make sense to, on the basis of pivotal, to say that the target hemoglobin should be dropped, say, from the 100 to 120 down to 90 to 110, if they're not doing well at that, if they feel poorly, fatigued, then individualize up?
Yeah, thank you, Kevin. I mean, I think that's a really good point. I think, if your patient isn't achieving the target you want on a lowish dose of ESA, even with, a higher dose of iron, I think you've got to reset you've got to just raise the concern that you might be pushing ESA too hard in that patient. So I think, in the patient who is, who is needing large doses of ESA to achieve a particular hemoglobin target that you are aiming at, ask yourself, could we do as well by setting that target lower, using less ESA, and protecting the patient from the potential side effects of the ESA?
One interpretation of the pivotal study, I'm sure that you're kind of alluded to, is that actually these aren't really large doses of ESA, and a change of 25% of them has important hard outcome change. And so do you think it is the surrogate that we can use, that the ESA dose dropping the ESA dose is the surrogate that should allow us to go lower target hemoglobins, or do we not have enough information?
Well, exactly. I mean, one interpretation of pivotal is that we protected the patients from ESAs with the iron, and that a 20% reduction in ESA dose led to those cardiovascular benefits, and that, right, that is one interpretation of the data. And if you believe that, then yes, I guess you use more intravenous iron to protect your patient from the higher ESA dose that you're needing to achieve, the hemoglobin that you want for that patient.
Do you think that the quality of life would be markedly different if you aim for 90 to 110 versus 100 to 120?
Not in my own personal experience of the type of patients who we have on our dialysis program, who are in their 70s and 80s and not that active. Right. 9 to 10 and a half is absolutely fine for many of those patients. Even though I don't have the time to ask them in detail how they're feeling, I sense that 9 to 10 and a half is fine, and they're not moaning about tiredness and dyspnea. So I think perhaps setting a lower expectation and achieving it gently, small dose ESA, more iron, might be a good way forward at the present time.
Right. Thank you.
I found your talk very interesting.
Thank you.
I'm the lone cardiologist who's been rung in. I'm interested in the people who have the thrombotic event, both arterial and venous. Is it in practice, then, do you alter the ESA dose and the iron dose, or do people just maintain the same practice?
So thank you. And we do look upon cardiologists as our example when it comes to the trials we should be doing. So we've done these cardiovascular outcome trials because we've seen what cardiology has been able to do in terms of shifting the evidence base and improving the treatments. I think that, we saw those events in the early days of ESAs when we gave big doses and pushed the hemoglobin up acutely. We used to use, 4 times the doses, 3 times the doses we're using today, and we used to see a lot more of these thrombotic events. The tragedy for us is clotting of the arteriovenous fistula, because we can't then dialyze the patient, and that's bad. So we do worry about these events. I think when we do see a thrombotic event of any type, I think there's a thought about perhaps a lower ESA dose, perhaps no ESA, and maintaining that patient with loads of iron, possibly even transfusions. And we have taken patients off ESAs because of thrombotic events, or even or recurrent thrombotic events.
We often see these patients with acute coronary syndrome. Then is this the underlying pathology, or how much does the ESA have to play into it? And
it's probably both, isn't it? It's a plaque with a rupture and then a sticky blood leading to the coronary event. I don't know, but I suspect that it's a bit of both.
It'd be interesting. I don't know if we've ever looked at the people who have their NSTEMIs where their hemoglobins are high or low, and their ESAs are high or low, right? It would be interesting because we have enough people coming in with their MIs, God knows. So it would be interesting to look at that, because you're right, we don't actually necessarily, but we also don't run very high ESA level doses here, and we don't run high hemoglobins. Yeah. But it would be interesting to see in those that are having events whether or not there's some differential.
But in pivotal, with the lower iron dose, we saw statistically fewer acute MI-labeled events, and these were all adjudicated by an endpoint committee in pivotal. So it's a proper infarct with an ECG and an enzyme rises, made available to the adjudication committee. So I think, there's something about less ESA, more iron, less MIs.
VGH, do you have any questions?
I have a question. Hi, my name is Isa. I'm a nephrology fellow at UBC. I just wanted to ask your opinion about HIF stabilizers and vascular access outcomes, because it's my understanding that in Rocky's, the phase 3 trial, comparing ESA to HIF stabilizers, there were more vascular access thromboses. And I'm just wondering if that's been shown in other studies, and if so, why that might be the case if ESAs are technically in physiologic levels and the hemoglobin levels weren't higher?
Yeah. So no, I've heard the same rumor. I haven't seen the detailed data. It's difficult for me to comment, but I think, you know, it could just be that any drug that increases your hematocrit increases your risk of thrombosing your vascular access, and you're not protected from that, you know, with a HIF stabilizer. So that's not a very good answer, but I think that's the best I can do. If this signal comes out, you know, from all the HIF stabilizer studies and in a meta-analysis, you know, is consistent, then I think we're going to have to think a little bit hard about how we can prevent that. That could be through gentle dosing, gradual increases in hematocrit rather than sudden increases in hematocrit, perhaps not achieving such high hematocrit targets, perhaps teasing out the patients who are at risk of this problem and treating them far more cautiously. But no, I have heard that, but I can't comment in any detail, having not seen the published data.
Thank you.
Go ahead.
It seems like the HIF stabilizers could get into the wrong hands thinking about athletes.
Yeah.
Do we have any data on that? Or?
Well, they're probably already in the wrong hands, I would suggest. You know, there's a black market for ESAs that I'm sure I shouldn't talk about. But, you know, these drugs are obviously appealing to anybody who wants to improve their physiological status. And you know, rather than training at altitude, you pop a pill and train in your own hometown. You know, that's potentially a misuse of these drugs, which of course is way off license, and I shouldn't make any comment.
Question? Well, thank you for a very stimulating Thursday morning talk. Thanks everyone for knowing that we changed the day from Friday to Thursday and for accommodating. And David's actually taking advantage of taking his family to Whistler on the weekend. So, and thank goodness there's snow.
Thank you for inviting me.
Thanks. There were 2 rooms at DGH, Brenda? Were there 2 rooms? No. Oh, because it looked like I and Sarah and all those guys were one place.